Welcome to This Explainer. Today, we're jumping straight into a fascinating intersection of human biology and clinical science. We are zeroing in on the NMC guidelines for clinical competencies, specifically looking at applied anatomy and the exact investigations used for breast disease. We're going to bridge the gap between pure structural anatomy and the actual life-saving protocols clinicians use every single day. So put yourself in this very common scenario. A patient discovers a physical lump, or maybe a routine screening flags something unusual. What actually happens next? How do we get from that anxious moment of uncertainty to a definitive, rock-solid diagnosis? Well, it's definitely not guesswork. It's a highly calculated, evidence-based process. In this explainer, we're going to see exactly how doctors play medical detective, using anatomy as their map and some pretty incredible technology as their magnifying glass. Here is our roadmap for today. First, we'll cover the anatomy of the breast, then applied anatomy and disease. Third, we'll dive into the triple assessment. Fourth is mammography and ultrasound. And we'll wrap things up with tissue sampling and staging. All right, Section 1, Anatomy of the Breast. Think of the breast as a highly organized secretory machine. It's built of about 15 to 20 lobes, and they're arranged in this radiating pattern. Honestly, a lot like the spokes of a wheel converging right onto the nipple. Every single lobe drains through its own lactiferous duct. This layout is absolutely crucial because it dictates exactly how fluids and potentially pathological discharges travel through the tissue. So, understanding this radial architecture, that's step one for a clinician trying to pinpoint where a problem is originating. If we zoom in even closer, we hit the microscopic powerhouse of the whole system, the terminal ductal lobular unit, or the TDLU. Made up of the terminal ductule and the lobule, this is, without a doubt, the most active part of the breast. It's essentially the operational headquarters, constantly responding to hormones like estrogen, progesterone, and prolactin. But here's the kicker, and why it matters so much clinically. Because it is so biologically active, the TDLU is the birthplace for the vast majority of breast diseases. When a doctor investigates a new lump, they are almost always dealing with a chain reaction that kicked off right here. Now, here's a really fascinating structural quirk, the axillary tail of Spence. This is a prolongation of breast tissue that extends from the outer part of the gland, passes deep through a gap in the fascia called the foramen of Langer, and goes right up into the armpit. Why does this matter? Well, because this tail lives in the axilla, if it gets enlarged, it's super easy for a doctor or patient to mistake it for a swollen lymph node or even just a harmless fatty lipoma. Knowing this specific anatomical tail exists prevents some major diagnostic slip-ups. Moving right along to Section 2, Applied Anatomy in Disease. First up, we have the ligaments of Cooper. Picture these as bands of fibrous connective tissue that act like a built-in suspension system. They anchor the breast to the overlying skin and to the deep pectoral fascia underneath. Normally, they just provide shape and support. But in a disease state, specifically cancer, they turn into a huge clinical red flag. You see, if malignant cells invade these ligaments, the resulting fibrotic reaction makes them contract and shorten. This literally pulls the skin from the inside out, creating a telltale sign known as skin dimpling. So if a doctor sees a dimple, their brain immediately jumps to the ligaments of Cooper. It's also super interesting how different anatomical zones breed completely different clinical issues. For instance, the larger central ducts, those are the classic breeding grounds for conditions like duct papilloma and duct ectasia. On the flip side, if you look at the smaller distal ducts way out in the periphery, those are prime real estate for fibroadenomas during a woman's developmental years and for cysts during involution. So just the physical location of an issue gives a clinician a massive head start in figuring out the pathology. Which leads us to a really foundational concept in modern medicine known as ANDI, aberrations of normal development and involution. This framework is a great reminder that a lot of benign breast lumps aren't actually diseases in the scary sense of the word. Take a giant fibroadenoma in a young woman, for example. Under ANDI, we understand this is just a normal developmental or hormonal phase that's kind of gone into overdrive. It's a normal physiological process dialed up to 11, resulting in a benign but palpable mass. All right, on to Section 3, the triple assessment. The triple assessment is basically the ultimate, foolproof security system for diagnosing breast disease. It leans on three very strict pillars. First, the clinical assessment. That's your detailed history and physical exam. Second, radiological imaging to get a look beneath the skin. And third, tissue sampling for microscopic analysis. When a medical team combines all three of these and the results align, the diagnostic accuracy is virtually 100%. It literally leaves no stone unturned. To give you an idea of those first two steps in action, a clinical physical exam often uses what's called the clock dial method. The doctor maps the breast just like a clock face to perfectly document exactly where a finding is, say a lump at 2 o'clock. Then, moving to radiology, ultrasound technology can actually guide a needle in real time to aspirate a simple cyst. It completely transforms a physical finding into an actively managed clinical event right then and there. Which brings us to Section 4, mammography and ultrasound. Now, how does a doctor choose the right imaging tool? Well, it's heavily dictated by the patient's age and their applied anatomy. Ultrasound is the absolute go-to for younger women, usually under 40. Why? Because younger breasts have denser, more glandular tissue that X-rays actually struggle to see through cleanly. Sound waves, however, navigate that dense tissue perfectly to tell a solid lump from a fluid-filled cyst. Mammography, on the other hand, uses low-voltage X-rays and is the first-line choice for women over 40. As tissue undergoes fattier replacement with age, X-rays can easily spot tiny microcalcifications. And then there's MRI, which steps in as a super-sensitive backup for complex cases or for patients with implants. If you compare different mammograms, the contrast is pretty wild. A totally normal screening mammogram shows these wispy, beautifully organized structural tissues spread throughout. But when there's an abnormality, your eye is just immediately drawn to a dense, starburst-shaped mass. It stands out like a sore thumb. That is the exact kind of radiological finding that screams for urgent, immediate investigation. To make sure every single doctor and radiologist on the planet is speaking the exact same language, they use a standardized grading scale called the BRA-ADS scoring system. It scores imaging from 0 to 6. Getting a 1 or a 2 means you're totally clear, basically a 0% chance of malignancy. But if a scan comes back as a 4 or 5, those are suspicious and highly suggestive. That score standardizes the next step instantly. It tells the team that simple observation is out the window and an urgent tissue biopsy is absolutely non-negotiable. For some context on what a BI-RADS 4 or 5 looks like on an ultrasound, it's a highly concerning visual. You're not looking at a smooth, perfectly round little cyst. You're seeing an irregular, ill-defined, solid mass that casts this dark acoustic shadow right behind it. It looks like it's aggressively invading the surrounding tissue instead of just gently pushing it out of the way. When a doctor sees this, it directly triggers the third and final step of our assessment. And that is Section 5, tissue sampling and staging. When we talk about tissue diagnostics, there are a couple ways to do it. FNAC, which stands for fine needle aspiration cytology, uses a tiny needle to suck out individual cells. It's super fast. But because it's only looking at loose cells, it actually can't tell us if a cancer has invasively broken through the basement membrane. That is exactly why the core needle biopsy is the gold standard. It uses a slightly larger hollow needle to pull out an intact little cylinder of tissue. This preserves the actual architecture, so pathologists can say for sure whether or not it's invasive. Now, if that core biopsy does confirm a malignancy, the detective work shifts to staging, figuring out if the disease has spread. A quick caveat, for early breast cancer, full staging is really only needed if the patient has symptoms. But for advanced cases, doctors bring out the heavy hitters. A CT scan of the chest, abdomen, and pelvis becomes standard. A PET-CT scan is amazing because it highlights hyperactive metabolic areas, which helps evaluate lymph nodes and distance spread. And an isotope bone scan is used specifically to hunt for osteolytic spread to the skeleton. All this data comes together to build a master map for a highly targeted treatment plan. As we wrap up this explainer, I want to leave you with something to really think about. We've just seen how a deep understanding of applied anatomy pairs up with these powerful, rigid diagnostic protocols to uncover disease. But as our imaging technology gets sharper and molecular diagnostics get insanely advanced, how close are we to a world where every single breast cancer is detected and maybe even treated at the microscopic level, long before a patient or a doctor ever feels a palpable lump? Mastering the foundational protocols we covered today is literally the first step toward that incredible future. Thanks so much for diving into this with me, and as always, keep learning.